Welcome to Bone Matters, where we examine questions and topics that matter to you. And today we're talking about something called atypical thigh bone fractures. Bit of a mouthful. You might see it written as AFF. Now, this is a rare side effect with some of the osteoporosis medicines. And you may be thinking, why are we devoting a whole session to it if it's so rare? Well, that's because we do get asked quite a lot of questions on our helpline. And we know that there are misunderstandings out there, and we'd like to try and sort that out. And we also know that these concerns about unusual fractures mean that some people don't start or continue their treatment, so their bones don't get stronger and they're missing out on the benefits. And we hope that this discussion will increase your understanding, reduce your risks of atypical fracture, but really reduce your unnecessary concerns. And we really want you to be able to take your osteoporosis medicines with confidence. So I am delighted to welcome an expert in the field to discuss this topic with me. Bo Abrahamson is a consultant endocrinologist. He lives and works in Denmark, but he works very closely with osteoporosis experts in the UK community and across the world, I think I can say. So welcome, Bo. And let me start by asking you, could you just explain what is an atypical thigh bone, sometimes called a femoral fracture, as a potential side effect? We're going to call them atypical fractures for short from now on, but it'd be really good to get your explanation to start with.
Yes, okay, and thank you very much for having me. Atypical thigh bone fractures or atypical femur fractures are breaks of the thigh bone. So it's a little bit further down the leg than where you have a hip fracture. So it is the same bone, but it's a little bit further away from the hip. And the surprising things about these breaks are that they can happen without any trauma. So they can happen without you falling or doing anything particular violent to your hip. And a couple of other things that are extraordinary about these fractures are that they are very unusual unless you have been taking medications for osteoporosis. They can be seen in some rare bone conditions, but they mostly happen in people who've been treated for osteoporosis with the most commonly used osteoporosis drugs. And another unusual thing is that they, in about one in three cases, they happen on both sides. So usually you would just break one hip, but with these femur fractures, you can actually have fractures on both sides. Would you like me to mention another unusual thing? Or is that?
Sorry. Anything else unusual?
Yeah, something that's also unusual is that there may be pain before the fracture happens. So people may complain about having pain in their thigh bone for some time, so in the groin or in the hip, for some time before the actual fracture arises, which is also different from what you have with a hip fracture, where you're fine until you fall and break your hip.
Right, really comprehensive picture of what a fracture is of this type. So thank you. So I guess people might be saying, well, why am I taking a medicine to stop me breaking bones, stop me fracturing? If it's going to cause a fracture, it kind of feels a bit counterintuitive. So why should I take them?
Yes, I mean, the important thing is that this type of fracture is so unusual that we still have a lack of information. So most of us haven't seen a huge number of people with these broken bones. So they're much less common than our usual hip fractures. So there's less knowledge. And if we look at the numbers, say for Denmark, which is the size of Scotland or Yorkshire, we have about 50 AFFs, or atypical thigh bone fractures, a year. We have about 8,000 hip fractures, and then we have all the other fractures due to osteoporosis. So that's a lot of broken bones, and very few of them are atypical. So the point is that the medications that we would use for osteoporosis very rapidly reduce the likelihood of suffering a broken bone, whereas only with long-term treatment does the risk of these unusual fractures begin to increase. So so this has to do with the type of medication, and it has to do with how long you take it.
Okay, so perhaps you could just remind us which ones people might wonder, which osteoporosis
Yes.
medicines is it linked to?
Yes, it's been linked to the bisphosphonates. So those are the most commonly used tablets for osteoporosis, say alendronate or risedronate or ibandronate. And it's also been linked to the type of medication you are given once a year in hospital as an infusion, zoledronic acid or a cluster. And it's also been linked to the injection given twice a year, that's Prolia, denosumab. And it's also been linked to the bone building drug Evenity or romosozumab. It's not been linked to the other medication. It's not something that's been linked to hormone therapy. It's not been linked to teriparatide, Forteo, bone building drugs of another class. So it's something that can be seen with the most widely used osteoporosis medications.
Right. And well, how do you know? How do you know if you've got an atypical fracture? It's different as you've described from it. I just wondered what the
Yes,
symptoms, the common symptoms are.
yes. I mean, as I mentioned, there can be symptoms before the bone really breaks. So some people will experience pain in their groin or their thigh, and you can have that sort of pain for other reasons as well. You can have it with you can have it with osteoarthritis and osteoarthritis in the hip. You can have it with spinal issues. So you can have that sort of pain. It's important if you experience that to discuss that with your physician and mention that you've been on osteoporosis drugs of these types, usually for many years, so that they have the complete picture. Because maybe they don't connect the fact that you've got thigh pain with the fact that you've been taking alendronate for 5 years. And then the thing that will need to be done would be a simple X-ray of the hip. You can do other types of imaging depending on the local preference, the local hospital service, what they like to do, but it's mostly just a regular plain X-ray of the hip. So that's the exam to do if you're worried that you may be developing an atypical femur fracture. And of course, it may break, it may run to completion. So this is getting a little bit technical, and I'm not an orthopedic surgeon, but my understanding is that you can have an incomplete fracture where there's a fracture line, but the bone still hangs together. And then at some point, this can run to completion. So there's a real break of the bone.
And does it
And
get
in that
better?
situation,
Sorry. Yeah.
in that situation, then you have acute pain and it's a broken bone, and you're going to need hospital treatment in the same way as you would for a broken hip.
Right. Right. So sorry to interrupt. Does it get better? People think, oh gosh, this sounds serious, but it gets better like any fracture, as you say, after the appropriate treatment.
Yes, well, it's going to need treatment, whether it's run to completion or whether it's an incomplete fracture. It will need surgical treatment. When these fractures first began to be seen, physicians would try to see if they could make them heal using other medications, or by taking the weight off the bone, would they heal over some time if you paused the osteoporosis drug? Would these fractures heal? And they very rarely did. I mean, mostly they would remain painful and they would run to completion later. So that was not a good strategy. The best thing was surgical treatment. So I think in today, the sensible thing would be to have surgery rather than hope for it to heal and go away.
Right, thank you. So we're talking about this being rare. What is the chance? What's the likelihood of this happening? Perhaps you could explain.
Yes. Yes, we've looked at that, and it depends very much on how long you're on treatment for. I know the official figure in leaflets and so forth is about 1 in 1,000. But But actually, that's too high. That's higher than what we've seen in Denmark. So we've seen this happen in less than 1 out of 10,000 patients per year in the early, in the early years of taking, say, a bisphosphonate, for example, alendronate, which is the most widely used in Denmark. And then the risk would increase, but it would remain really quite low. So with treatment until 5 years, there'll be 1 out of 5,000 people each year. So that's just by way of illustration. That's a little bit less than the number of people who can sit in the Royal Albert Hall. So I think that's about 5,000. So
Right.
so 1 in 5,000. And if you take, say, alendronate for more than 5 years, your risk may be 1 in 2,000. So the 1 in 1,000 is probably a little bit on the high side, and it certainly only applies to those who need to take osteoporosis drugs for several years.
Okay. And within that range, we've described it as quite a low incidence. Are there people who perhaps are more likely? Are there other things that put you at risk?
Yes, there is. The risk is the same in men and women. That's new information. We didn't really know much about the risk in men because there were fewer men on osteoporosis treatment, but the risk is very similar in men and women. But ethnicity makes a big difference. So in the Southeast or the South Asian subcontinent, these fractures are much more frequent. So if your family is of South Asian origin, your risk is probably about 5 times higher than if you come out of a white European family, and also your hip fracture risk is lower. So there's a little bit higher risk and a little bit less to gain. So that's unfortunate. It's there's a little bit less of a treatment need, if you like, but there's also a higher risk of adverse events. But it's still a very low. I mean, even if you do the numbers, the benefits are absolutely much larger than the risks of atypical thigh femurs in women from South Asia as well. But it's just the benefit is just not as overwhelming as it is in Europeans.
Anything else apart from ethnicity that might make you more at risk?
It's been looked. People have looked at diabetes and prednisolone and so forth, but I don't think it's probably fair to say that the results are somewhat inconsistent there. So it's the most important risk drivers are ethnicity and how long you're on treatment for.
Right. And people also ask, does it matter how you get your drug? I mean, if you take it by injection, are you more likely to get it than if you have a tablet? Do we have any evidence there?
We don't know that there's a difference. Again, the numbers are low for all of those studies that I've looked at. It hasn't really been possible, to my knowledge, to show that injection was, say, more dangerous than using the medication as a tablet. Yeah,
but length of time, you say, is significant. We know it's, as you say,
that is definitely, it's consistently,
use. We do get asked, why is it these particular drugs? Is there any understanding as to why that is in these groups?
Yes, I mean, these are medications that more profoundly affect the turnover of bone than what happens, say, with hormone replacement therapy, or hormone therapy, as we like to call it. So it's a more powerful type of medication, and also for the bisphosphonates, they stick around in the skeleton, so they actually get deposited into the bone, and that may also matter.
Right. Okay. Thank you.
But that's also the advantage, because that's why they keep working for some time after you stop them. And that's an interesting mechanism, because if you look at the overall picture, then for your broken bones due to osteoporosis, the protection sets in very quickly, and the protection remains active for some time after you stop taking the medications. In some people, that can be several years. Whereas for the atypical fractures, the risk is not immediate. The risk sets in very slowly. And once you stop taking them, it's the opposite. It goes away very, very quickly. So that's the reason why pauses are considered helpful here. Because looking at data from Sweden and the US, it appears that when you stop taking osteoporosis drugs, your risk of these atypical fractures, always a very low risk, but it declines very rapidly. So that risk goes down by 2/3 in 1 year. So it's a risk that's slow to develop and very quick to go away. So that's the reason for the pauses. And you can have the pauses because the protection stays on for some time.
That's really helpful. Perhaps just taking that on a little bit step further, some people won't be offered a pause in treatment because it's felt they really need. Is that because they need the full dose, as it were? They want the kind of maximum benefit. Is that the thinking?
Yeah, it is. I mean, the difficulty is really people at low risk, because you don't want to be over treating someone who doesn't have a high risk of breaking their bones. But if you have somebody who's got very severe osteoporosis, most of us would be very worried that they would have serious fractures if they came off their medication. And there would be no real purpose in doing that if we only prevented a really rare type of fracture and then put them at risk of all the common fractures. That could be much more dangerous.
Right. Okay. So it's going to be a personal judgment, isn't it, based very much on an individual situation. And people might say, well, yeah, and people say, well, what else can I do? Is there anything else to reduce the chance of one of these rare side effects?
Yes, I mean, we don't really know. I mean, we haven't got any lifestyle advice to give out. We don't know if it matters if you quit smoking. We think you probably should give up smoking, but we don't think it may not affect this. I'm not aware of any way of modifying this risk other than giving the medications for a timely period and reassessing whether you still need to be taking the medication. So I think it's important to tell people that this is something that many people can stop taking for a bit after 3 or 5 years. But if you have severe osteoporosis, it's something you may need to keep taking.
So having a regular review is a good thing, because you can
absolutely good. Absolutely a good thing. Yes. Just
a little bit more then about these fractures. If you, as we say, it's unusual, but if you had one, if it's suspected, you've talked about the tests and the symptoms.
Yes.
Can you still walk around and go on as normal? Because sometimes people worry that there's a possibility and it's being looked at.
I'm always keen to see an X-ray. But when my patients mention this, I do worry that they do something to make an incomplete fracture run to completion before we've diagnosed it. So, but the risk is very, very low. But I think it makes sense to play it safe and not, don't go out jogging or, do anything dramatic. Try and, until you've had the X-ray, be a little bit careful and try not to exert yourself too much.
But you don't have to lie down. It's about kind of normal activities.
No, not that. But quite a lot of these fractures have happened when people have been out jogging, running.
Right.
So I think that would probably be one thing to avoid until the X-ray has been done.
Yeah. Thank you. So we have to keep stressing this is a rare problem. We don't want people to start being over concerned.
No.
But if you unfortunately did have one of these fractures and you have osteoporosis and an increased risk of further fractures, what happens next? People do ask. Does it mean you can't ever go on medication again?
Yes, it's very, very difficult. It's the most difficult of questions, I think, because it's so individual. It would be nice to be able to come off treatment in that situation and then maybe wait several years and be reassessed, and then maybe at some point later in life start treatment again. But it sort of comes down to how severe osteoporosis you have and how worried you are about breaking other bones. And it also comes down to something quite as simple as, do you have any hips left to break? I mean, if you're all metal in your thigh bones, say if you had one hip replaced for some other reasons a few years back, and you then have an atypical femur fracture in the other thigh bone, well, then you've got metal in both hips, and perhaps your main concern then probably should be that you don't want to have broken bones in your spine, and you don't want to break your humerus. And in that situation, the odds are different. You may say, well, in that case, I want to be actively treated. I'm not worried about the other hip. It's metal. I'm fine. But in somebody who still has a hip at risk, it's a different conversation. And yes, you can treat people again, and you can treat people again with the same drug, but you have to have a conversation with people about their risk profile and their concerns, and are they happy to take this again? Are they very worried about breaking other bones, or would they be willing to face a somewhat higher risk of breaking other bones, but then knowing I'm not taking anything that's going to interfere with anything in my skeleton? It's a highly personal decision, and of course, as physicians, we also risk averse. We don't like it if people come back to us with problems that we feel we've helped create. So your physicians will probably also be quite worried about treating you again. And if you really want to be treated, that could also be a difficult conversation if the physician would rather you didn't, because what if that happens to the other hip, and it would feel awful, feel really awful if we felt we'd caused that.
Yeah. So it's a complex one, and why you would obviously need to see a specialist in the field who help make a decision that's right for you. So do seek advice. Do make sure you're seeing the people with the knowledge. So thank you. Really, we've almost come to the end. Lots of really useful information. Thank you so much. Perhaps I can ask you, have you got any final messages that you'd like to give to our audience who are listening today?
Well, I think the most important thing is to be open about this. I mean, it's no good physicians saying this would never happen. I mean, we've all seen it happen, but it's a rare occurrence. So I think we should be honest, and we should own them as fractures that we may have a role in having caused, but we'll have prevented so many more fractures. And the difficult thing for the doctor is that those patients are not going to know it. They're not going to be in your clinic thanking you for, oh, it's a good job I didn't have that hip fracture last week. And we just have to learn to use these medications in the best possible way. So for a reasonable length of time, timely pauses, and having a good conversation with the patient about, what are you worried about? What can we offer? Is there stuff we can do to make the risk smaller?
Thank you. No, that's been really, really helpful. Thank you so much. And to all of you out there, of course, you have to make your own decision about taking a treatment, about a medicine, but we hope that being well informed, it's so important. We hope this conversation has been useful for you. So thank you so much, Bo, and to you all for listening. And you'll find many more Royal Osteoporosis Society resources and information listed below this film.